Good morning. Welcome to another session on behalf of Clinical Epidemiology Unit CMC Vellore. So as we have been having in the last few weeks, we have been having series of sessions on core grade, and we will continue with the same this week. So this week we'll be having a summary of the sections 6 and 7 as part 4 of this particular series. And we'll continue to have Dr. Reba who will present this series as well. And we are once again thankful to Professor THARYAN sir for having agreed to moderate this session. Thank you very much, sir, for having come. And without any further delay, I'll hand over to Dr. Reba.
Good morning, everyone. Welcome to the last and the final part of understanding the core grade approach. So over the past few weeks, we've been looking at the essentials of grade, which is called the core grade, which has been used for helping people conduct systematic reviews, as well as helping them to identify important outcomes, rate the importance, to synthesize evidence, as well as to summarize the findings. We also looked at how we use core grade to rate the certainty of evidence. And today we'll be looking more on this part, how decision makers actually use this evidence and how they consider other important criteria to formulate the recommendations. We looked at how to rate down for imprecision, inconsistency, risk of bias, indirectness, publication bias. We also saw how to rate up for dose response as well as large effects for non-randomized studies of intervention. These 5 papers have been covered over the last 3 weeks. So this week, we'll be looking at the 6th and the 7th paper. That is to present the evidence in the summary of findings table and how to move from evidence to recommendations and decisions. If you want to watch the previous YouTube videos, you can go to our CMC Vellore page and watch the remaining parts. So let's move on. So today we'll be looking at the components of the summary of findings table, how to present dichotomous outcomes, how to present continuous outcomes, and we'll also be looking at additional considerations. So what is the summary of findings table? So this is a key grade innovation. Basically, it's a structure which helps present benefits and harms that clinicians, patients, and decision makers require to guide their choices. It helps us to systematically present numerical results like relative and absolute effects that show the impact of intervention for prioritized patient outcomes and also the certainty of evidence. Now, this is an example of a summary of findings table which was adapted from this particular systematic review. This looks at intensive versus less intensive anti-leukemic treatment in older adults with acute myeloid leukemia. So if you look at this column, on the rows, you have the outcomes. So the mortality, you have remission, and you also have serious adverse effects. So this first column, it tells you where the evidence is coming from, the number of participants and what kind of studies. For example, for the first outcome mortality, you have 1,821 participants in the overall review, and the evidence is coming from 11 non-randomized studies. The next column tells you the relative effect. That is the summary of the systematic review for a particular outcome. So for example, the hazard ratio for mortality is 0.78. In the next column, you have the absolute effect. So what is the actual incidence in the less intensive anti-leukemic treatment, and what is the effect, what is the rate in the intensive anti-leukemic treatment? And you have the risk difference. The next column tells you what is the certainty of evidence of this particular estimate. And in the last column, you have the plain language summary, which basically tells the clinician what is the interpretation of this evidence. And at the bottom, you have the footnote, which is basically how the authors communicate the justification for rating the certainty of evidence. So usually footnote has to be very succinct, it has to be explicit, and it has to be very transparent in how they rated the certainty of evidence. We also saw how to actually put forth the wording for the certainty of evidence. For example, if my evidence is high certainty, I'll be very confident it either reduces, increases, or has no effect on a particular outcome. If my evidence is only moderate certainty, the terms I would like to use would be it probably or it likely reduces, increases, or has little to no effect. If the evidence is low certainty, the wording which we should use is may or possibly. And if it's very low certainty, we have to write it as evidence is very uncertain or the effect is very uncertain. We also looked at what are dichotomous outcomes. These are basically outcomes for which you have a yes or a no answer. For example, mortality. Now, how do you present dichotomous outcomes? So you can present as relative effects or as absolute effect. So relative effect would be relative risk, odds ratio, and hazard ratio. And absolute effect you can present as absolute risk difference or number needed to treat. This was the picture which we got from the core grade 2 paper, which looks at 3 different populations. And on your y-axis, you have the absolute risk of event. And after an intervention, the event rate comes down from 30 to 20. Over all the 3 populations, you see that the relative risk is actually 0.67, but your absolute risk difference actually changes. Over here, it's about 10%. Here, it's about 3.3%. Over here, it's 1%. So what you notice is, even though the populations are different, your relative risk is more or less relatively consistent. But your absolute effect will vary based on your baseline characteristics. And another example was the 20-year-old patient with no comorbidities and the 89-year-old with many comorbidities. The same intervention, the mortality reduced by 50% here and here, but the absolute effect was just 1% here and 20% here. So the relative effects are similar, but your absolute effect of the intervention is different because both have different baseline characteristics. That is why many people who conduct meta-analysis or systematic review, they prefer to use relative effects to actually do the meta-analysis. One is because if you use absolute effect, you will have inconsistency across all the different studies in your review. And if you use relative effects, it's more or less consistent. And for you to compare between different studies, you want the effects to be consistent. So that's why we choose relative effects. So mostly, you would have seen relative risk being presented in summary of findings table, because this is very easy to interpret, and it also helps you to calculate your absolute effect. Odds ratio, on the other hand, is very difficult to interpret. But you can use it if your baseline risk is very high. That time the RR is not very meaningful. Hazard ratio is usually used in studies where your outcome is mortality, where you have a high death rate, especially in oncological studies, which not only tells you if death has occurred, but also when it has occurred. So for survival, duration of survival, this is a very important tool. But on the other hand, for a patient, they're more interested in the absolute effect. If my mortality is going to reduce by 1%, I might not opt for a particular intervention. So that is why it's important for summary of findings table to include also the absolute measures. They have to provide the risk differences. So to generate the risk difference, the relative risk estimate that you get is applied on the baseline risk. I'll give you an example. Here, this is a summary of findings table for awake-prone positioning versus usual care in patients with COVID-19 or type 1 respiratory failure. So for the outcome of mortality, if you look at the baseline risk, how much is it? It's 165 per 1,000. Now, how do you get this particular number? So ideally, if you look at RCTs, they have a lot of very narrow inclusion and exclusion criteria. So the incidence in the RCT might not actually represent the whole population. So ideally, you're supposed to get this baseline risk from a large cohort study or a systematic review of observational data or a very pragmatic RCT, which is not always feasible. So what systematic review authors do is they look at the median risk in the placebo arm for all the individual studies, and then they pull it together and get your baseline risk. So for this particular review, you find you got a pooled estimate of 0.93. That means the relative risk reduced by 7%. So you apply this on this, and you get this final absolute effect, which is 154 per 1,000. So the mortality reduced from 165 to 154. Sometimes when you're doing a study, you might find that you have as a clinician, you're actually interested in prognostic factors. The same intervention might act differently if you have different baseline risks. So for example, in this study, when they looked at SGLT2 inhibitors and GLP-1 receptor agonists for type 2 diabetes, when the systematic review authors, when they looked at the population, they divided them into 5 risk categories. Very low risk is when the patient population had no or 2 cardiovascular risk factors. Low risk is if they had 3 or more cardiovascular risk factors. Moderate risk is when they had a cardiovascular disease. High risk patients were classified if they had a chronic kidney disease. And very high risk, they were classified if they had a chronic cardiovascular disease or a chronic kidney disease. Their overall mortality odds ratio was 0.77. So these authors, they have actually looked at the subgroup analysis and found that the odds ratio was same across all the subgroup analysis. So you would have thought that they could have presented the data as just a single row. But what the authors have done is, they have presented for 5 different groups, and they looked at the baseline risk factor. So for very low risk population, the incidence in the control group was only 20 per 1,000. But on the other hand, for very high risk group, the likelihood of death was how much? 265. When you apply the same relative risk, that is 0.85, you find that the absolute effects finally change a lot. So for example, in the very low risk group, the absolute effect was only 3 fewer deaths per 1,000. In the low risk group, it was 10 fewer deaths. In the moderate risk group, it was 18 fewer deaths. In the very high risk group, it was about 40 fewer deaths. The MID for mortality was actually 10. So in the first group, it was not significant. You had an effect, but it was not an important effect. But on the other hand, for the very high baseline risk, you had a large effect. So actually, when they did the recommendations, so for they had a weak recommendations against using SGLT2 inhibitor in the very low group, and they had a strong recommendation for it in the high risk group. So here you can see that even though the relative risk is same across all the individual groups, because your baseline risk factor was different, your final absolute effect was also different, and the recommendations is different for both the groups. So now we looked at how to present dichotomous outcomes. Now let's look at continuous outcomes. So what are continuous outcomes? These are basically numerical variables within a range. So examples of outcomes with continuous outcomes would be duration of illness, duration of hospital stay, what's a functional status, what's a pain score, what's a quality of life. Sometimes you'll have studies which use the same measure of outcome. So for example, you're looking at knee arthroscopy versus conservative management with in osteoarthritis. Suppose a systematic review has 6 studies. Each of the study has presented their pain as using the visual analog scale. This makes it very easy. So finally, when you have to interpret the data, you look at the mean difference using the natural unit or the index scale, which is the visual analog scale. So for example, let's look at that prone positioning for COVID-19. So if you look at the ICU length of stay, in the no prone positioning, you had 10.3 days. But the patients who had an awake prone positioning, you had 8.5 days. So here you can see that you're looking at the mean difference. That is, there was 1.78 lower number of days. Now what happens if each of the study gives you different outcomes? For example, study 1 and 2 is giving you pain score in numerical rating scale. Study 3 and 4 is giving you pain in the visual analog scale. Study 5 and 6 is giving you the outcome in a knee osteoarthritis outcome score. So here you have different instruments to measure pain. So you have 3 options. So the first option is you use one particular scale, convert everything to that scale. Second thing is you convert the data into binary outcomes. And third thing is you use something called standardized mean difference. So let's look at the option 1, where you use one particular scale. So if most of the studies have used this particular scale, that is the knee osteoarthritis scale, which is 0 to 100, and higher the score, the better outcome. So I will use this as my index scale. Suppose my study has reported the outcomes in the Western Ontario scale. The scoring is from 0 to 68, and higher score means worse outcome. So what do you do for this case? So what you must do is you must convert it into the 0 to 100 score. Then you must reverse the direction of your scale. Suppose a study has used the arthritis impact measurement scale, where the range is from 0 to 10, and higher score means better outcome. This is very simple. You just multiply that into 10 to convert into the Coase scale. Suppose I have used the SF36 survey outcome, which is also 0 to 100, and higher score means better outcome. Here, there is no need to do any conversion. So, for this table, they have basically presented the findings in the 3 different options. So look at the first option. That is the pain. They have told you the time frame, which is 3 months. They have told measured by different instruments and converted to scale of index instrument, which is the Coase scale, which is 0 to 100, and higher scores means better outcome. This is very important for you to actually include in the study summary of findings table. You must mention the scale as well as the range and the outcome. Here you can see that the mid is 12. That is the minimal important difference is 12. Final difference is how much? 5.38, which is, there is an effect, but it is not important. Okay, so they have mentioned it as knee arthroscopy probably does not result in an important reduction in pain. Now let's look at option 2, presenting data as binary outcomes. So what you can do is, if you know the MID for each scale, I can assume a normal distribution of the results. And for all the studies which have used this particular scale, I can find out how many of the patients had MID for this particular scale and how many were below the MID for this particular scale. I will do the same for the next scale as well as the next scale. So finally, what I will do is I will pool the relative risk, saying this many number of patients had an MID in their scales. This many number of patients didn't reach their important difference in the scales. So the same data is presented as the second option. That is, in the conservative management, they had 669 per 1,000 patients reaching the MID. In the arthroscopy, there were 793 per 1,000 patients reaching the MID. So the difference was around 124. But here, the quality of evidence was low in this systematic review. So the third option is to actually use the standardized mean difference. So what is that? Basically, you find the mean difference between the two treatment groups, that is the treatment and the control group, and you divide by the standard deviation. So the formula is this. You basically convert that unit of the scale into a standard deviation unit. Now, there are a lot of problems with this conversion. Number one is you're expressing the size of your effect by the variation. So finally, it's very difficult to interpret. It's very difficult to interpret what is standard deviance rather than the actual scale, unit of the scale. Second is arbitrarily, we've taken a threshold of 0.2, saying that if it's more than 0.2, it's an important benefit. But many clinicians are skeptical of this threshold. Third thing is, as you can see, this actually depends on your variation. Suppose I have the two different RCTs, I have the same magnitude of benefit. But if one population is heterogeneous, my standard deviation will become wide and my SMD will become small. On the other hand, if I have a homogeneous population, my standard deviation will be less and automatically my standard median difference will be large. So you only use it if you have multiple scales, but you don't know the MID for each of the scales. So for this same outcome, the SMT improved by 0.16 in the intervention group. I told you that 0.2 is the cutoff. So here also you have a difference, but it's not meaningful. So sometimes you notice that if you use all the three options, you might have concordant results. That means you're very confident in the magnitude of your results. But if you have some discordance in some option, some methods is showing benefit, some it's not showing benefit, that means you're less confident in the magnitude of the effect. Some additional considerations for summary of findings table is choosing which outcomes to present. So ideally, core grade advises you to use only 7 outcomes. But sometimes as a clinician or as a patient, you might want to see the effect of an intervention at different time points. You might want to present the data using different ways, either as a dichotomous outcome or as a continuous outcome. Or you want to look at the evidence from both RCTs as well as observational studies. And sometimes if you're not able to synthesize the result, the core grade authors might want to give it as a narrative format. So for all this, what you can do is, if you want to present more data, you can use online supplementary materials, or you can use this digital publication platforms where you can have overlay techniques, and you can have additional summary of findings table and interactive designs for you to communicate all your data. But you just have to make sure that your outcomes are not overlapping. There is no point putting an outcome for all-cause mortality and also putting another outcome for cardiovascular mortality, because then you'll be double counting the adverse effects. Okay, so what happens when you cannot pool the data? So for this, the hematological study, looking at the complete remission, they had 4 studies which reported this outcome. 3 of the 4 reported a shorter remission with intensive treatment, and the difference in duration ranged from 3.1 months shorter to 0.03 months. Sometimes when you're unable to pool the data, you can just make a narrative summary into your summary of findings table. And another important thing is actually to present the burden of treatment. So many times in a summary of findings table, you'll probably say, okay, SGLT2 inhibitor is better for a patient. But what does that mean for a patient? So you must actually consider, so patients will actually want to know, how do you give this medication? What's the frequency? What's the route? They probably want to know what tests and visits they should do to monitor the effect of this intervention. They'll probably want to know how it will affect the physical well-being, how it affects the emotional well-being, the social life and relationships, the work and education, travel and driving. So now co-grade actually it encourages us to actually present all these findings. So I'll give an example. This is a guidelines developed using the MAGIC app. So this is looking at adults at very high risk of CKD progression. They're looking at SGLT2 inhibitors. So here they've written, we recommend administering SGLT2 inhibitors. So here, if you click on this button, you get the research evidence. Here, if you click on this button, you get evidence to decision. And here, if you click, you get practical information. Here, if you click, you get decision aids. So if I click on that, the next pop-up tells you what aspect of treatment would you like to discuss. Do you want to look at the all-cause mortality or cardiovascular mortality, etc.? You also have an option for practical issue. If I click all-cause mortality, I get a pop-up screen saying, for 1,000 patients like you, if I give you SGLT2 inhibitors, the 48 fewer patients would die. So this actually helps the patient to make a decision. And they've also given the evidence certainty. If I clicked on this practical issues, I come to a next pop-up screen, which if I click on each, it will tell me the medication dose. For this particular example, it was all gray. That means they had not uploaded the information for this particular example. And another example, looking at women with HIV who are pregnant and who want to initiate combination antiretroviral therapy. So again, if I click on that, I came across this table, which it basically tells you the risk for each outcome. And it also tells you the practical aid. So when I click on the medication routine, it tells me the tenofovir you give once daily medication. With the alternative therapy, you need twice daily medications. If I click on the tests and visits, it tells me with NFO, you just need regular blood and urine tests for kidney function. If I used Abacavir, I would need to do a HLA B5701 testing. So this actually is very easy for patients to use it. Sometimes you might have evidence only from indirect. So this example I had actually told last week itself. So when they were looking for mechanical versus bioprosthetic valves in chronic dialysis, they found there was no benefit in the outcome. Mortality was same in both arms. When they looked at the side effects, that is the gastrointestinal bleeding, they found out that their evidence was very, very low. So what they did is they looked at they combined RCT evidence from a different study which looked at warfarin and placebo. So basically, mechanical prosthetic valves will require warfarin. So they've applied indirect data into their systematic review and they have downgraded for indirectness. What do you do if you have only non-randomized studies? As we talked about in core grade 4, non-randomized studies will start off with a lower certainty of evidence and you can upgrade based on the dose response curve as well as the large effects. So that gives you an approach on how to actually do a summary of findings table. Now we'll move on to the core grade 7, which basically tells you how to move from the evidence to recommendations and decisions. So we have seen how to assess certainty of evidence. We have seen how to create summaries of evidence. Now we'll move on to recommendations. So here, the people in the guideline development are the decision makers. So how do they actually decide on the direction of the recommendation and the strength of the recommendation? And what is the implication for a patient or a clinician? So when you look at a guideline development group, there are a lot of groups actually involved. You have the main guideline development group. You have a steering committee, which is made of less number of people who will actually help you formulate the PICO statement. And during your meetings, they'll sort of like set the agenda for the meetings. You also have a very important team called the systematic review team who actually are involved in the finding the evidence. So they actually find the evidence and give it to the development group. So who are involved? So you have technical experts, you have clinical experts, you have end users, that is clinicians who are actually at the top of the field. So like George Eliot said in Middlemarch, no man can judge what is good evidence on any particular subject unless he knows the subject well. So you need to have experts on the subject. But you also need to have patients, methodologists, economists, experts of equity, human rights. Because it is a narrow mind which cannot look at a subject from various points of view. So if you look at what kind of recommendations they make, there are only 4 categories. They recommend strongly against a recommendation, conditionally against a recommendation, conditionally in favor of a recommendation, strongly in favor of a recommendation. Very rarely, they might recommend saying use of either, and sometimes they might say only in research setting, but these two are very rare situations. So if you find that your harms are way more than your benefits, you will recommend against. If you find your benefits much more than the harms, you will recommend for an intervention. When you find that the magnitude is not so different, you would give a conditional recommendation. And another way to look at it is, if there are a lot of well-informed patients sitting in the audience, how many of them would actually recommend for an intervention? How many of them wouldn't? Okay. So the next important thing is, what actually determines your direction and strength of recommendations? To facilitate this decision making, you have a lot of framework that is called the evidence to decision framework. You have the grade and you have the co-grade framework. So the primary factors which actually guideline developers use is the benefits, harms, and burdens, the certainty of evidence, as well as the values and preferences. This is actually looking at an individual patient perspective. But you must also consider population perspectives. That is your resources and cost effectiveness that you would need, the feasibility, the acceptability, as well as the equity. So when you look at benefits and harms, if your benefits are very large, more likely the panel will make a strong recommendation. If your harms and burdens are large, the panel is going to give you a strong recommendation against the intervention. The higher the certainty of evidence, if it's a higher certainty of evidence, panel is going to strongly recommend for an intervention. And it's also important about the patient's values. Sometimes patients will value the benefit. Then the guideline panel will recommend for the benefit. Sometimes patients will value the harms. Then the guideline panels will actually recommend against the intervention. Then you also look at the costs, you look at the feasibility, the acceptability, and the equity also. So if you look at the core grade, what they tell you to do is, you first have to decide on the perspective. From whose point of approach are you doing this? You look at the individual patient perspective alone, then you look at the benefits and harms, burdens, and values and preferences. If you're looking at the secondary population perspective, you might have to look at the cost and feasibility also. Then the next most important step is actually to get your MID right. Once you get your MID for all your critical important outcomes, then only you start your trade-offs, which will come to that later. Okay, so yeah, so the first step is once you have ranked your outcomes, you must rate your outcomes and see which is your critical and important outcomes, and you need to get the MID for those outcomes. Last time I had told you what an MID was. This is a null effect. Sometimes you have to establish a range saying, okay, -10 plus 10. If my value falls in this, that means there is no important benefit. Only if my value crosses this threshold, I would say it's an important effect. So what is the importance of choosing MID? First, it's very important for you to rate the certainty of evidence for imprecision as well as inconsistency. So here, just a revision. This study, the point estimate is above the MID threshold. So you will not rate it down for imprecision. This particular study B, you can see that the confidence interval is crossing the MID threshold. So here you will actually rate it down 1 for imprecision. This study is also similar. You will rate it down for imprecision. Whether you use a null threshold or the MID, this one you will definitely rate it down for imprecision. And we also saw how you need that MID to rate it down for inconsistency. Suppose I had taken the null threshold as my target, all the studies would have been consistent result. All of them are on one side of the null threshold. But suppose I'd taken MID of -10, you find that 8 studies are falling on this side and 5 studies are falling on the other side of the threshold. Then I would rate it down for inconsistency. The next important use of an MID is it actually tells you the importance that you are placed on the outcomes. For example, mortality, if I take 1% MID, stroke I have taken 2% MID, for MI I have taken 3% MID, and for GI bleed I have taken 5% MID. That means I consider mortality to be 5 times more important than my bleeding risk. So for mortality here, if my point estimate was 3%, it's a significant effect in terms of mortality. But if I'm taking it as a GI bleed, it's not at all significant. It's not important. So how do you actually get your evidence for MID? So the most important thing is you must actually look for studies and systematic reviews which have looked at patient values and preferences. It's called patient-reported outcomes. Suppose you have those studies available, you do the systematic review of all the MIDs. So for example, a guideline, people wanted to recommend shoulder decompression surgery for patients with chronic shoulder pain. So they wanted to look at what is the MID for the outcomes. So they have done prior to it, they have looked at a systematic review looking at the MIDs for all the patient-reported outcomes. So this group, they looked at all the studies which are looked at shoulder interventions, and they have looked at all the outcomes that they have used in all the different studies. And they have finally chose out MIDs which are actually credible, and MIDs for scores which are not so credible. And they used a criteria for credibility assessment. So here you can see the pain visual analog score. The MID they have taken is 1.5. For the constant score, they have come with an MID of 8.3. And if you look at the final systematic review, which is subacromial decompression surgery for shoulder pain, they have actually recommended against the subacromial decompression surgery. So if you click on more details, it tells you the evidence. So here you find that for pain, function, quality of life, all of them showed there was no important difference. If you click on this more, it tells you you get another pop-up screen, it actually tells you the final result. So for pain, it was 2.6, and after non-operative is 2.9. Here the MID was 1.5. Where did they get this MID from? From the previous systematic review. Similarly, for the next one, function, they have looked at the constant score scale, and here they have taken an MID of 8.3. This also they have got it from the previous systematic review. So this is how you must do if you have MIDs available for your outcomes. Sometimes you find that the MIDs are actually not available. So what can you do? Sometimes what guidelines do is the panels themselves launch new studies. But this is not always feasible because they have time constraints, they have resource constraints. The second thing is to actually use focus groups with small number of patients. So if you look at rheumatology, the ACR, when they develop the guidelines, they usually have focus group discussion with patients. The third thing which you can do is see clinicians who are actually experienced in conducting shared decision making with patients. So here you get a lot of informative answers. So for example, pregnant lady who are at risk for thrombus, you have to give them anticoagulation during pregnancy. So you have two options. You either give warfarin or you give heparin injection. What do you think as a patient they would prefer? Would they prefer warfarin or would they prefer heparin injections? Sorry? Warfarin, right? So, but actually the clinicians told that they would actually prefer heparin. Why? Because warfarin is associated with fetal abnormalities. But with heparin, you have a lot of burden for the patient. But mostly pregnant women would actually give more importance to fetal abnormalities. So this sort of unique perspective you get from clinicians who actually handle those cases. But the only problem is you're actually open to biased inferences. Sometimes when you can't do any of these, the other option is the guideline panelists themselves will decide on the MID. So how they do it is by using the panel survey approach. So let's look at an example. Suppose they're making recommendations for an intervention. They're looking at the risk of MI. Okay, so now the question is, what is the smallest reduction in MI that patients would perceive as important? Okay, so the panel leader will ask a question. In adults considering this intervention reduces the risk of MI by 1,000 over a period of 5 years. So how many of you would think this is an important benefit? Your intervention is going to reduce the risk of MI by just 1 in 1,000 patients over 5 years. Do you think it's important? No. Suppose I say it reduces the risk by 20. Is it important? Yes. Is 3 important? What about 15? It's important. What about 5? How many of you think it's important? How many of you don't? Okay. What about 10? What about 8? What about 12? Okay. So they go across these questions and they finally look at everybody's responses and they take the median value. So this particular guideline panelist, they have taken the median value was 12. So your MID becomes the value at which half the group will say it's important and half the group will say it's not important. Okay, so now we all understood how to choose MIDs. Now the next point is how to look at the benefits, harms, and burdens. So for this, you need the summary of findings table. Let's look at an example, which I already showed, awake prone positioning for COVID-19 patients. Okay, so usually they found in patients who are mechanically ventilated, prone positioning helped. So they want to see, does it really work in COVID-19 patients who are awake? So let's look at the outcomes. So let's look at mortality. So there was 12 fewer deaths, but the confidence interval was wide from 0.79 to 1.09. And those are low quality evidence. What about endotracheal intubation? The relative risk was 0.84 and the confidence interval was 0.74 to 0.94, which is moderate benefit. And ICU length of stay also there's some benefit. So if you look at all the benefits of prone positioning, it probably reduces mortality, it reduces the invasive ventilation. But what are the harms and burdens? How many of you have actually prone patients here? So during the COVID time, we were proning patients. Let me tell you, it has a lot of patient side effects. They have discomfort, they have pain. After eating food, they have to lie down prone, they'll have vomiting. Most important is their central venous catheters coming out. Okay, and it's very difficult for nurses to do round the clock prone positioning. So when you look at the benefits and the harms, what do you think? Do you think if you're a guideline panelist, you have two options. As a panel, you can place a high value on the modest reduction in invasive mechanical ventilation and a lower value on the patient discomfort. Or as a panel, you can place a lower value on the benefit and a higher value on the adverse effect. What would you choose? How many of you choose option 1? How many of you choose option 2? Option 1? Option 2? Okay. So if you look at this guideline panel, they have actually suggested prone positioning and they have given you a justification also. They have told the panel placed a high value on the reduction because of invasive mechanical ventilation and they placed a lower value on the adverse effect. Why do they feel that? That's because if the patient found any adverse effect, they can always just go back to their supine position. So they have considered this values and preference, they have made a judgment. So usually when you have, like in COVID-19, many of our interventions didn't really have a straightforward benefit. So you must actually compare it with very large harms and you make a decision. But if you have a good certainty of evidence, it's very easy to make a judgment. And you must also look at the population issues. For example, this blood cell transfusion, their question was, should you give transfusion if the HP is 7 or should you give transfusion if the HP drops less than 9? So you have a liberal strategy and you have a restrictive strategy. As a patient, I would want a transfusion if my mortality was going to reduce, but I also don't want the adverse effect. But as a population, I had to make sure that there are enough blood in the blood bank to give to patients who actually need it. So you have to look at the individual outcome as well as the population outcome. So the guideline panels have looked at both and they found out that there was no major difference in the mortality in both the groups. So then the next step is they looked at the population outcome and then they have made the strategy saying you only transfuse blood if it's less than 7 grams per deciliter. So this is an example of how you also look at the population outcome. And another important example of population outcome was remdesivir. So if you actually looked at remdesivir, they had the COVID WHO guidelines had given a weak or a conditional recommendations in favor of remdesivir. But if you look at the evidence of remdesivir, the hospital admission rates in the moderate risk and the high risk group was significantly less. It actually was a very beneficial drug. But they only gave a conditional recommendation because it's very difficult to give remdesivir in an OPD basis. So for you to come and get remdesivir, you will have to come to the hospital, get injections. During COVID-19, there was a lot of staff crisis. We didn't have enough nurses to come and give the medicines. And not all people could travel up and down to the hospital. That is why the panel considered the complexity of giving the injection, and then they have given a conditional recommendation. Yeah, so when you construct the recommendations, you decide the directional recommendation first, and then you decide on the strength. Usually, if you have low certainty of evidence, you never give a strong recommendation. The only exception is if you have a very high risk of death. For example, giving FFP or vitamin K for patients on warfarin with intracranial bleed. There is no strong evidence. But what is the alternative? The alternative is death. That's why you make a strong recommendation for giving vitamin K or FFP. So I've given you the broad principles of the co-grade approach. So let's just wrap it up by looking at an example. So imagine all of you have been invited to create clinical practice guidelines for an institution. Our job is to recommend short-term steroids for hospitalized, non-severe community-acquired pneumonia. So let's have a baseline poll. How many of you would recommend steroids for non-severe community-acquired pneumonia? Okay, we have 2 people for giving steroids. How many of you will not give steroids? Okay, we have majority. So let's look at it. So when you want to make guidelines, there are some few online apps. One is the Magic app and the Grade Pro. Grade Pro is sort of free. Okay, so let's just assume that Phenisha is doing the systematic, she's part of the systematic review methodology team, and she's going to provide the evidence to the guideline panel. So she has gone and she's looked at this article, which is corticosteroids in community-acquired bacterial pneumonia, a systematic review, which we have actually gone through in detail over the past 2 weeks. So if you look at the objective, they have taken the population of adult patients who are hospitalized for community-acquired pneumonia. Intervention is steroids with standard of care. Control is standard of care. Outcome is mortality, need for invasive mechanical ventilation, secondary infections, etc. GI bleed, ICU admission, and the time is 90 days. So if you look at the subgroup analysis, they have already told that patients with severe community-acquired pneumonia probably benefit from steroids. They have also decided they will do an analysis for high risk of studies versus the low risk of bias studies. And the MID that they have taken is 1% for mortality. For all the other outcomes, they have taken 2% as MID. And for all your continuous outcomes, they've taken 1 day as your MID. So if you look at all the individual studies, if the study had mostly non-severe population, that entire study was called a non-severe study. If more than 50% of the patient had a high port PSI score or was ventilated or required ICU care, they have labeled the study as a severe study. So you have a mix of non-severe studies as well as severe studies. Yeah, so let's look at how to generate an MID relative risk. So here, what MID have you taken for mortality? 1%. But that is the absolute effect. You have to convert that into relative effect to actually put it into your forest plot. Okay, so if you look at the formula for calculation, the formula is absolute MID divided by the baseline risk. Okay, so for example, for very severe pneumonia, my baseline risk for mortality is 14.6%. If I want to convert that into relative risk reduction, I have to divide 1 divided by 14.6. 1 is my MID, 14.6 is the baseline effect, which I will get 0.068. Then to get this range, I have to minus it from 1. So for example, for severe pneumonia patients, mortality, my MID will now be 0.9322 to 1.068. You understood, right? All of you understood? Okay. You saw this, mortality was 14.6 is the baseline risk. You divided that 1. So just look at the baseline risk. Here you have your risk with usual care, which is how much? 146 per 1,000. So what's your, in percentage, how would you present that as? 14.6. MID is taken as 1%. So 1 divided by 14.6 is 0.068. My relative risk reduction will be how much? 0.068. I have to minus that from 1. So 1 minus 0.068 will give you 0.932. If I add 1, it will become 1.068. So my MID, if I say is 1%, on the forest plot, it will translate to how much? 0.932 to 1.068. So for the next one, for the less severe pneumonia, this is what is our target population. What is our baseline risk? 7.5. And 1 divided by 7.5 is 0.125. 1 minus 0.125 is 0.875. So here my MID for this is 0.875 to 1.125. So like this, you have to actually make MID for all your outcomes. Okay, so now let's look at, so Phanisha has to actually now do what? She has to now rate the certainty of evidence. So let's all rate the certainty of evidence. Now the first outcome is what? Mortality versus severity. So the authors have presented the less severe data. They have also presented the more severe data. They have presented their overall summary statistics. Would you write this down for inconsistency? We actually went through this 2 weeks back. So no. Why? Because first the authors have already, before doing the study, they have done a subgroup hypothesis. They have established an a priori hypothesis. Then they have gone ahead and done the study. Then they have looked at to see if there's any difference between the less severe group as well as the more severe group. And they found out that there was a subgroup effect. Okay. And now they're testing the hypothesis. And they have presented the data for less severe pneumonia. So we just have to look at the less severe pneumonia. So it's not inconsistent. Is it indirect? No, because we have evidence for the less severe pneumonia. Is it imprecise? What is your point estimate here? 1.08. Your here your confidence interval is 0.83 and 1.42. If you look at your MID, your MID is 0.875, 1.125. Your confidence interval is crossing your MID on both sides. So how many times will you rate it down for imprecision? 2. So I will rate this down by 2. And looking at the text, they said there's no risk of bias or publication bias. So what certainty of evidence will you give this now? High, moderate, low, very low. But you rated it down by 2, right? So you'll give it a low certainty of evidence. So let's look at the authors. So they have also given all-cause mortality, relative risk is 1.08. They have also given it down for low due to serious risk of imprecision. Now let's look at the next one, invasive mechanical ventilation. So here, in both the groups, there was no subgroup effect. So you can actually look at the overall pool data. Okay. So again, for inconsistency, I would say no. Indirectness, I would say no, because there was no major difference. The other thing is, what about imprecision? Your point estimate is 0.562 and the confidence interval is 0.42 to 0.74. Your MID is 0.75. So it's above your threshold. Okay, so I will not rate it down for imprecision. Okay, and there is no risk of bias or publication bias. So I would give this as a high certainty of evidence, this thing. So similarly, the authors also have given this particular outcome a high certainty of evidence. So systemic corticosteroids reduce the risk of needing invasive mechanical ventilation. Okay, what about let's look at the adverse effects. Yeah. Yes. If you're, so she's asking, even if there is non-inferiority, would you rate it down for inconsistency? Yes. So for example, I'll show you in this picture. In this picture, I'm actually saying this is non-inferior. But if you see the confidence interval, there is a chance that this could be beneficial. There is also some chance that this could actually be harmful. So you must rate it down. Okay, let's look at all the adverse effects. What are the adverse effects of giving steroids to a patient? Hyperglycemia, infections, and GI bleed. So let's look at infections. So they found that, yeah, so for inconsistency, I would not rate it down. There's no subgroup effect also. And you can see all the confidence intervals are overlapping. Indirectness also, no. Imprecision, if you look, the overall point estimate is 1.019, 0.85 to 1.41. And the MID is 0.741 to 1.25. So on one side, it's actually crossing your threshold. So I would give this a moderate evidence. And here also they have given us moderate, that is systemic corticosteroids have no effect on secondary infection, but this is moderate evidence. What about GI bleed? Overall, there is no inconsistency, there is no indirectness. Now here I want to tell you an important point. So if you look at the initial table, the baseline risk for GI bleed was actually 17 per 1,000, which is how much? 1.7%. Can you reduce MID 2% out of 1.7%? If your baseline risk is 1.7%, you cannot have a negative risk. So here you can have only MID for harm, which is 2.17. And you find that the overall confidence interval was up to 1.6. So I would say this is a high quality evidence saying that there is no benefit between the both the groups for GI bleed. Okay, and so similarly, they have also rated it as high certainty of evidence. Sorry?
You can't go less than 0. I suppose you can't have minus for that.
Yeah. But your mortality was 14.6.
It didn't go to minus.
It doesn't go to -2. See, if you look at this mortality, the baseline risk here is 14.6, 7.5, 8.2. Even if you look at the infection rate, it's 77, 7.7. You can have a minus on that. But how can you have a minus on 17 per 1,000 when your overall... Yeah. So actually, if you see, no, the original systematic review authors, they have actually downgraded this for... this is actually wrong, actually. So how did they get a MID for this outcome? They have written here as... one second, this is E. The confidence level crossed at MID. So I was trying to calculate confidence in MID, and I could not understand how they got this, what to say, this particular rating. But the core grade authors who have used this example have got the correct rating, which is high certainty of evidence. Which one?
Why do you think serious representation? No, previous slide. It crosses one side.
It crosses one side.
No, the word serious is what I'm one down.
One down.
Very serious is two down.
Look for the first one.
One down is serious. Two down is very serious.
Yeah. So here it's very serious. Okay. So this is very serious. This is just serious. Okay. So for GI bleed also there is no difference, and it is a strong evidence. Another outcome they looked at was ventilator-free days. For continuous outcome, what was the MID? 2 days. But if you look at this, no, these two trials, ESCAPE and Confaloneri, both of them were high risk, they were severe pneumonia patients. So actually, I would have rated it down 1 for indirectness, and for imprecision, I rated it down by 1 because it crossed your MID of 2. So I would have given this a low evidence, but the authors have given this as moderate. So I have just put that as a star with gray because my rating did not actually... These two studies are only severe pneumonia studies. Yeah. Non-severe. So I wouldn't say this directly applies to our question. Okay. Sorry, sir? So they're proportionate.
That proportionate was more towards less severe.
But they were more severe. Yeah. If they had taken everybody, I would not have rated it down because I've taken only 2 particular studies for this outcome. I have rated it down. Okay. So now continuous variable you don't. You just look at the mean difference, which is 2. So here you can see that the mean difference is 0.95 to 4.85. Okay. Okay. So now we are the guideline panel. We have got this full evidence. What is our evidence here? All-cause mortality, no change. Need for invasive mechanical ventilation, it has improved. Secondary infections, GI bleeding, no major adverse effects. What about ventilator-free days? Okay. So now, so when we go ahead, first we have to define a question. Should short-term systemic corticosteroids versus no systemic steroids be used for adult hospitalized patients with less severe common acquired pneumonia? So we should define a population or intervention or comparison and our main outcomes. What was the setting and what's the perspective and the background of a study? So if you look at the background, the American Thoracic Society has actually recommended against giving steroids. The next, in 2023, the European Society has told you can give steroids for severe pneumonia, but they have only recommended for shock patients, not for patients who are actually requiring ICU care and all that. And the 2 important studies, ESCAPE and Cape Cod, has come after this guidelines. That's the background why we are actually developing this particular guidelines. So let's look at all the questions which as a guideline panel, we have to go through. So how many of you think that this is a problem? This problem is a priority? No, probably, yes, yes, varies, don't know. Yes. Okay, so the answer is also yes. Okay. Desirable effects. How substantial are the desirable anticipated effects? Your answers are trivial, small, moderate, large, varies, don't know. Okay, so I would have also said moderate, but they have said it's a large, large benefit. Okay. Undesirable effects. How substantial are the undesirable anticipated effects? Is it trivial, small, moderate, large? Trivial, no. There was barely any difference. Okay, so I would say trivial. They have also said trivial. Next one, values. Do you think that the people would, what importance will the people place on the outcomes? Will it differ among all of us? Will all of us agree on the same outcomes, or will our values be different? Okay, so some people are saying it's possibly important uncertainty or variability. But for this, though, you should actually have a study. Okay, so there is this common database, which basically, it tells you all the patient-reported outcomes for each disease. And you should have a baseline study saying what is, in this particular patient, I find this is my important value, like important outcome. For example, the COVID-19 study, when they had to do they recommend on the multi-system inflammatory disease, they actually looked at the patient outcomes and the population outcome. So there was no outcome, so they told there could be some variability. Next is balance of effects. Does the balance between desirable and undesirable effects favor the intervention of the comparison? This is where we actually have to decide whether you're going to recommend or not recommend. So how many of you will favor the comparison, or how many of you favor the intervention? How many of you want to give steroids? But we saw a lot of benefit, right? Okay, so more show of hands for this. So even this example, the guideline panel, they have also favored the intervention because you have more benefit rather than trivial harms. Now the next part of question is to actually look at the population. How large are the resources required for giving steroids? Do you need a lot of resources? No, we don't. So it's negligible cost or saving, right? The next question is, what is the certainty of evidence that you know that it doesn't require this many resources? High, because all of us have used steroids. We have used it in different settings. We all know the cost of steroids. So we would give this high. Next thing is, does the cost effectiveness of the intervention favor the intervention of the comparison? It favors the intervention. I've just done a small calculation. The number needed to treat to prevent one invasive ventilation is about 25. Okay, so the cost of a course of steroids for 1 week is actually rupees 35. If you take the prednisolone 40 mg once a day dosing. Cost of treating 25 patients to prevent one outcome is 875 rupees. What's the cost of one ICU admission? It's more than 60,000. So it obviously favors your intervention. What would be the impact on this on your health equity? Do you think all the patients can access this intervention, or only some patients can access the intervention? Everybody can access. So you will see that the impact is actually, the equity is actually increased, or probably increased. Do you think it's acceptable, this intervention? It's unacceptable. Do you think it's feasible? Yes. So finally, after you've done all this, you have to summarize all your answers in a big table called the summary of judgments table. So now finally, what is your recommendation? Strongly recommend or conditionally recommend? Okay. So if you look at the examples, they have actually conditionally recommended for the intervention. In immunocompetent adults hospitalized with less severe community-acquired pneumonia, we suggest administering a 7-day course of steroids. They have given a weak recommendation. They have also given the reason why they have given a conditional recommendation. So this wraps up our core grade series. We have looked at rating certainty of evidence. We have also looked at the guideline development process. Thank you.